Good evening. Today we are going to talk about joint replacement. Many of you have some family members who end up having some joint surgery. Longer stay in the hospital, large incisions, infection, complication, and the recovery time, it takes sometimes months. So imagine these days when in this program we try to promote the advanced technology in Northwest Ohio. And we are proud to present a new technology where the joint replacement is much simpler. Smaller incision, shorter procedure, recovery time is very short and hospital stay does not exceed more than 1 day, and the patient within about 2-3 weeks back to their normal life and probably back to full exercise activity. That's what we want to introduce to you today, advanced technology about joint replacement. Join me today to welcome our expert in joint replacement, Dr. Carlos Gomez from Wood County Hospital, who was doing some of these advanced technology for the last few years and has a tremendous experience with it, and I hope you will enjoy our program.
Begin by describing the knee joint. The knee is a hinge joint formed by the thigh bone, or femur, shin bone, or tibia, and kneecap, or patella. The end of the femur has two rounded protrusions called condyles, similar to the rockers on a rocking chair. They provide smooth rocking and gliding motion against the top of the tibia. The hinge joint provides stability through a wide range of motion. A healthy joint moves freely and painlessly as a person moves. With arthritis, bone grinds against bone, causing pain and limited movement. This animation shows how the joint functions, both normally and when problems occur.
Would I recommend other people for replacement knee surgery? Yes, I would, very strongly. Biggest thing that bothered me is I waited too long. I waited way too long to have this done. I went through the pain too long, and the surgery was just it was very simple, very painless.
I am a walker. I go to the woods absolutely every single day of my life, no matter what the weather, in all the seasons, with my dog. And I couldn't walk anymore at all. And it was, my life was over. And I'd sit there and look at the dog, and then I'd watch my son have to take him out, and he really didn't get the walks and the fun because that's my own personal time. And you go out, and there's nothing like going out in nature. And when that's taken away from you, I got into this depression, and I was ready to give up. I was just totally ready to give up, and I felt like I was 90 instead of 66. And now, I gave myself 4 weeks after the surgery. And 4 weeks after the surgery, I took my first walk in the woods, and it felt wonderful.
Good evening. This evening, it's my pleasure to discuss one of the most common subjects patients always talk about, knee replacement, hip replacement, and that concept which is coming from increasing frequency and the rapidly probably the arthritis problem which is leading to a significant amount of procedure lately. And talking about the technology and the advancement of this kind of surgery is so important. For that reason, it's my pleasure to welcome Dr. Carlos Gomez, who is one of the specialists orthopedic in general orthopedic trauma and mainly specialized in hip and knee replacement to my understanding.
Yes, sir.
Thank you for coming.
Thank you for having me, doctor.
One of the first questions, let's define what's joint replacement.
Well, a joint replacement is remove arthritic or deteriorated cartilage from a joint. And it can be addressed in pretty much every joint in our body. It could be our shoulders, it could be our wrist, it could be our fingers, it could be our hips, our knees, or even our ankle.
I understand. But the most commonly two things, to my understanding, and correct me if I'm wrong, are the hip and the knee replacement, because we hear it very commonly done. And when we're talking about the hip and joint and knee replacement, what are the most common causes for that decision that you need a knee replacement or you need a hip replacement?
Well, definitely pain. Most of our patients come to visit and see us because of pain. And that's what they want to get rid of, as well as motion and lack of activities. We have a lot of patients, younger patients, older patients, that are not able to do any type of activity, and that limits them. So after pain, I think the lack of motion and limitation on the motion is what is the second cause for them to.
Now, if there's any specific period of time we have to say that, okay, you reached to that peak level, we have to interfere surgically at this point? I mean, because not every patient's having some joint pain, we're going to tell them you need a joint replacement, knee replacement.
Correct. And the way we address it is very simple. We make sure that this patient is seen by us, and we have a physical examination where we determine the lack of motion they have, the pain, the deformity they have. And based on that, with x-rays initially, we can start doing some type of treatment. We start always with conservative treatment. And with that, that entails the patient needs to lose some weight. They need to be active to maintain range of motion and strength. We use a pain medication like anti-inflammatories and physical therapy to recover from that. If we see that that patient is not recovering and everything is deteriorating, then we move forward to try injections. That it could be just a simple cortisone injection, or it could be a viscose supplementation, or the use of braces. If that still didn't help and the patient still is doing all the conservative treatment with losing weight, maintaining the strength and the motion, then we can discuss the possibility of a total knee replacement.
So if we talk specifically about the knee replacement, I mean, let's start with that. And the patient's coming to you and went through all of that process of rehab and conservative measure and medication and injection, and nothing is working. You make a decision that they need to have a joint replacement.
Correct.
Now, there's, to my understanding, for the knee replacement, there is a partial and there is a total knee replacement. Can you differentiate when we should use one of the others?
Yeah, a partial knee replacement is a more specific procedure that it has certain specific candidates there. Not everybody is a good candidate for it. It only, if it's a medial or lateral compartment, there's only one that is deteriorated, we can approach that. But with the good motion, good strength, and determine which side is the one that needs to be changed. In a total knee replacement is when we see that all the compartments are pretty much deteriorated at that point, that don't give us the option to have a partial knee, because it's going to need a full replacement of that particular knee at this point.
What is the percentage of the patients who require total versus partial?
A lot higher for a total.
For the total are more common.
Yeah, it's about 80 to 20 in my practice.
And to prepare a patient for having a knee surgery, definitely there's steps. Do you mind to tell us about, from your expertise, what are those steps? When we're talking about pre-surgery, what kind of testing needs to be done, prevention needs to be done?
So once we address the condition with the patient and we know they're ready for a procedure, we set up an appointment with the anesthesiologist. We call pre-anesthetic testing. So they meet our anesthesiologist and define which is the best way for them to go through the procedure, either general anesthesia or a spinal anesthesia. They have all the blood work done at that point, and we discuss also, very important, the family support, because if the patient doesn't have the family support, I like them to go to a rehab place from the get-go. Otherwise, the patient's not going to do well. We like also to contemplate the possibility of home rehab if that's another opportunity to do it, or do as an outpatient for rehab. And once we have that settled down and we know that everything is being ready for this patient, we start talking about doing the procedure. And then we have a date, and we make sure that all the blood work and everything that we already did from before is apt. I call them the fine-tuning of the patient. Make sure that if a patient has a cardiac problem, we send it to their cardiologist and have that taken care of. Or we send a letter to our primary care physicians to be part of the team, because this is all about having the same team working for the best of our patients at this point.
Now, are the patients who are going through the total knee replacement have the same criteria for the blood thinner in relation to possible building up clot in the leg? Because that's a very common question with the orthopedic patient. Is that the case in total knee replacement, or it's not that?
No, as a part of the parameters that we have a protocol, and we use blood thinners in every single patient because of the risk of a clot. Okay. Definitely. And so at this point, we are using a oral blood thinner. Okay. We used to use the injected blood thinner, sure. But at this point, if you give them a chance and say, you want to pick which one do you want, that's a no-brainer, and they'd rather go with a...
Which is really proving also it's the same or equal
Correct.
in benefits, so that's
Correct.
why we have to take the shot.
During a total knee replacement, your surgeon will replace your knee joint with a prosthetic knee. Bones in the knee joint include the lower end of the femur or thigh bone, the tibia or shin bone, and the patella or kneecap. Smooth cartilage, called articular cartilage, covers the bony surfaces, cushioning the knee joint and allowing the parts to move easily. The most common cause of knee disability is osteoarthritis, which causes the articular cartilage to wear away, resulting in severe knee pain and stiffness. When pain medication and other treatments are no longer effective, your surgeon will perform a total knee replacement. During the procedure, your surgeon will remove the damaged cartilage and bone and reshape the bony surfaces to fit the prosthesis or artificial joint. Your surgeon will cement up to 3 prosthetic components into place, including a metal femoral shell, a metal and plastic tibial component, and a plastic patellar component. Before closing the incision, your surgeon will bend and rotate your knee to ensure it functions properly. Over 90% of patients experience dramatic pain relief and improved knee function and have a new joint that will last 10 to 20 years.
Is your heart clock ticking?
We love French fries. G3 looks the same, but each makes a difference for your health. This large fry at a typical fast food restaurant has 500 calories and 25 grams of fat. This small fry has 230 calories and 12 grams of fat. This fry comes from the grocery stores, 160 calories and 6 grams of fat. So, which do you choose? Because remember, time waits for no one.
Why become a foster parent?
I wanted to give back.
I wanted to help a child.
It's something that I felt called to do.
We heard about the need and we knew we could do it.
We missed having kids in the house.
Being a foster parent just fits with our family.
I'm Dean Sparks from Lucas County Children's Services, asking you to become a foster parent. Call us at 419-213-3336, visit us at lucaskids.net, or find us on Facebook.
Now bring us really, which is, I was amazed when you were explaining to us about what you do, guys. I understand in Bowling Green Center, they are doing a tremendous advancement comparing to the rest of the center in town, which is doing the total knee replacement in a specific technique. Yes. And that's different from the traditional knee replacement, which I heard and I seen before. Do you mind to take us step by step with the details of why you do it that way and what are the steps to do that process?
Great question. And yeah, we've been doing total knee replacement for years. And I think that we all have the training to do it the traditional way that I call, sure. Because that's the way we were trained. And I know all the surgeons are very skilled to do it. Mm-hmm. So to have a little notch to it, up a little notch to that, we have a MRI-based procedure that it really not only makes it easier in our patients, but also in us as surgeons. Uh-huh. So we need to use that technology in our advantage. So I brought some models here that I want to show you, if you don't mind. And this is a knee where we are definitely going to show how we do a traditional way. We make some, after we open up the knee and get into the joint, we make this hole in the femur as well as we make one in the tibia for the alignment that we need to give to this knee.
So this is above the knee and this is below the knee?
Correct, mm-hmm. Correct. Once we make that, in order to make sure that the cuts that we make are accurate, we use a rod mm-hmm. to get inside the joint and gives us the alignment that we need to do based on the head, the center of the head, the center of the knee, and the center of the ankle. Sure. And we do that not only for the femur, but also we do it on the tibia. So with that, we definitely have a alignment that we need to get on our patients. And definitely making a big hole brings one of the problems and complications that we can have is that there's bleeding from the bone marrow that bleeds a lot, and it can cause a collection of blood. Sure. and cause pain in the immediate post-op of the patient, delaying their recovery. So for that reason, what we have done is in this past 3 years at Wood County Hospital is bringing an MRI-based, then we not only have a plain film, but it's a 3D reconstruction of this patient's knee where it shows exactly where the arthritic changes are on this knee. And based on that, they will not only mark these jigs with the patient's name, my initials, and also the size. We know exactly the size that this patient is going to have. And so the MRI makes these jigs as well as it makes the cutting jigs. They're very specific for the patient, so we can put our pins and resect the bone that we need to resect. Even tells me here that I need to cut 9, 5 millimeters or 10 millimeters, and distally as well. So we know exactly how much are we going to cut on the femur, or we're going to cut in our tibia as we put our jigs, put the pins, and it tells me how to do it. So it definitely gives a better alignment compared to doing it with just only based on an x-ray. And the patient's recovery is a lot faster.
So the way I understand it right now, you are telling me that every patient will have an MRI.
Correct.
That MRI, you design the joint for that specific individual.
Yeah,
and his name comes on the joint.
Correct.
And then you go and install it or put it in the right spot for that patient.
Correct.
Offers a new technology called Signature Personalized Patient Care. The Signature system utilizes custom femoral and tibial positioning guides developed from MRI. When you're ready, click on a circle. During traditional total knee replacement, surgeons use X-rays to size the implant components before surgery. During the procedure, multiple instruments are used to position the guides for removing damaged bone and cartilage. Traditional total knee replacement sometimes uses instruments placed inside the femur, thigh bone, and/or tibia, shin bone, to assist with implant alignment and positioning.
I really didn't have a quality of life before my surgery. I'd say 2 months, probably 3 months before I had the surgery, I couldn't walk anymore. So my days were spent just sitting in a chair, feeling sorry for myself, toddling around the house with my cane or holding onto the furniture, until my son talked me into making an appointment at the doctor's. And I tried a cortisone shot, which, oh my God, it lasted for 3 glorious days. And then it stopped working. And I went back to the doctor's and I tried the Synvic. It's an injection, and that did not work at all. It felt worse after than before. My son took me, and we sat there in his office, and he showed us a little video and everything that it entailed. And I'm sitting there just, oh God, what am I going to go through again? So after I saw the little video, I saw that this was a complete different one, because I had had knee surgery 7 years before this, prior. And it was like completely different. So I said, okay. And it took me a month to get all the stuff, the process going, and all the tests and the x-rays and everything. And then after the month, then I was ready to go and get it done. The surgery, he was in and out, Dr. Gomez was in and out so fast that I had half the swelling that I did on this leg. And to compare the two, I don't think there's any comparison whatsoever, from the pain, from the swelling, from the time in my hospital, to the physical therapy. It was like everything was cut in half. Completely, the time limit was cut in half. And my attitude on this one was, wow, I got through this and it was so easy. It was so easy. It amazed me. It really did.
Okay. Prior to my surgery, I could not run. Running was very painful. It was extra shock on my knees. My knees would even tend to swell up if I exerted too much force. And then after the surgery, I was able to run. I don't do a lot of running, but the fact that I couldn't before and now that I could just mentally meant a lot to me.
So this is definitely so far advanced in comparison with the traditional and the painful one. I think that's really painful. So the difference is related to the management beyond that. I understand it's less complication.
Yes.
What is the most common complication which we are not going to see it as frequent other than bleeding?
Well, probably clots is one of the most common complications after that. Again, infection is something that we got to keep in mind, but it's pretty much similar doing it this way or the traditional way. But the recovery time definitely is a lot faster in this patients.
So
yes.
Can we get an example? For example, in this way, what's the recovery time versus the traditional one?
Well, it all depends as well on the patient.
Okay.
Every patient's different, and sometimes our patient will more thrive to get their recovery process being more aggressive on the therapy. But we think that about 4 to 6 weeks is when our patients are back enjoying that knee at that point.
Wow.
Yeah.
That's amazing. And when you are talking about this technology, I'm sure every physician who needs to do this basically has to have a special training. Not everyone is trained. I mean, not every center can do it.
Well, again, here in Toledo, we were the first ones to start it, and then some other physicians started doing it here as well. Okay. And it's an MRI that is certified for the program, that have the software specific to develop the jigs. So again, we work with a company that has helped us out on doing this procedure, and we've been doing it again. I've done over 900 of those in this past 3 years, so we're very pleased with our results.
Wow. And when you compare, I'm sure you did some other patient with traditional way.
Correct.
And when you compare the traditional way to this advanced technology, definitely you are.
I'm very pleased with the results, no doubts. I
always make it so personal for everybody and trying to promote the idea about what's better treatment for the patient. So if it's your mom, your dad are the one who need a knee replacement, would you recommend this technology or you recommend the traditional way?
That's a very, very great point. I see my patients like my family, and that's what I bring to them. I say, hey, you are like my family. What do I want for my family? What's best for you? And at this point, we need to use the technology in our advantage, in our advantage of our patients.
Absolutely.
Yes.
Absolutely. Now, do you think this technology is moving forward toward some other joints, like the hip joints?
Yes.
And
There's soon we're going to hear about the same technology for hip replacements.
Unbelievable. Do you notice any difference on the long run between the traditional versus this technology?
Well, as I said, we've been doing it for 3 years. So at this point, our results are in a good direction, showing that they are doing pretty much as the literature shows in patients that have done it for years, the traditional way. So what we expect is that we can use this procedure in younger patients. Okay. And I've done it in a 40-year-old, and I've done it in a 92-year-old. Sure. So I think the longevity of the prosthesis is going to be a lot longer because of the new technology and the new components that we have as well.
Now, sometimes I see patients who had a knee replacement and then over the years deteriorated and they could require a second knee replacement.
Correct.
What's the chance with this technology? Is it the same like traditional way?
It depends. It depends on the level of activity of the patient.
Okay.
We try to tell them that it's like your car. When you buy your car, it's a brand new car, but as you use it, it's going to start to wear off. So we want them to be careful and to listen to all the recommendations that we have to last longer. Again, we have new technology as well in polyethylene that is going to make it last 50% longer than what we usually have for about 19 to 20 years. So it is important to use all those factors and see every patient is different, but usually it should last longer than what we have at this point.
And again, you said that you almost did about 1,000 cases in Bowling Green so
Correct.
far. That's a huge number, you know that.
It's a good number. It's a good number. We're very happy. We're very happy. Our patients are happy. We have had a few complications, you know, as you expect.
Sure.
The more surgery you do, the risks are there.
Now that brings us, I mean, we always try to help the patient also from the financial standpoint. Is it all of the insurance in general cover this procedure?
Yes. I've had only one problem with one insurance, but most of the major insurance will cover them. And I haven't had any issue. I mean, it's 99.9% of the insurance will cover it.
Oh. And the same way they need definitely a rehab or physical therapy after the procedure. Correct. For a few weeks to recover 100%.
I had my right knee replacement done on early January, of 2012, and my second one was done in October of 2012. Actually, I was off work both instances for 3 weeks. 3 weeks, and I was back, and I was doing therapy after, but I did go back to work after about 3 weeks on both surgeries. The quality of my life prior to my first surgery was very painful. I had trouble descending steps. Going up steps wasn't too bad. It was just any initial shock, constant shock. I lost the cartilage in both of my knees, and so it was pretty much bone on bone rubbing, and it was very, very painful. It's actually changed pretty dramatic. I'm not taking any more pain pills. Pain is virtually gone. I can climb around on stuff. I have a boat, and I can climb around on that with ease, and prior to that, I just struggled, and it's just changed my life, pretty much.
And I have my good days, and I have my bad days, but not my knee days. My knees are always good. I have osteoarthritis in my other joints, but not in my knees anymore. And if I hurt anywhere else, I still feel good in my knees.
Thank you very much. We appreciate your input and your expertise, and we wish you the best of luck. And we wish Bowling Green Hospital also more advancement in technology. I mean, I think that you are ahead of many centers in this area, so we congratulate you for that.
Thank you very much.
Thank you so much.
Thank you very much. Thank you for having me.
Thank you. At the end of this program, thank you for watching. I hope you enjoyed it and you learned enough about joint replacement, specifically the knee replacement. And I hope you learned enough from our expert talking about this specific procedure, which is very advanced, and he is very well trained and qualified to do. And I hope at the same time, if you need more information, to reach Dr. Gomez in Wood County Hospital through the contact information we are going to show at the end of the program. Remember to talk to your doctors. Always discuss these options. Our goal is to introduce the option to you, and then your doctors can tell you what is the best for you. And remember also that our advanced technology is getting better every day, because we want the patient to have less stay in the hospital and better recovery, and definitely better and a cure for their problem. Because remember, time waits for no one.